Greetings, I'm Kritika Saxena. I'm a clinical psychologist and I work with clients of clinical disorders. In our last lecture, we had seen how to take case history. What are the right kind of questions to ask the client to be able to elicit a chronological order or a timeline which has led up to their symptoms and that they have come to see you. Now we will discuss mental status examination or MSC. MSC is what you mostly observe, see, notice, and that's about the client's behavior, their posturing, their verbals, their non-verbals, their speech. Let's see how it can be further divided. It's a sum total of the examiner's observations and the impressions that the client is making in the interview. The case history, it remains stable. MSC changes day to day, even hour to hour. So if I'm taking an MSC today, it can look different in the MSC for tomorrow. It can even, when the patient is mute, incoherent or refuses to answer any question, that is also when you can take an MSC. Because like I mentioned, we are looking at the behavior, we are looking at the posturing, we are looking at the gestures, we are looking at the non-verbals, the expressions, the micro-expressions, how they have kept themselves, how they are presenting themselves. So a client who is not cooperative, who refuses to answer your questions, is sitting silently, muted, maybe they are not in a coherent space, they can also go through MSC. The description of the patient's appearance, speech, actions and thoughts is what needs to be explored. Most of the components of MSC are general appearance, the attitude towards the examiner or the clinician, and the behavior. Furthermore, the speech, the productivity of that speech, their mood, affect, the way that they're thinking, the way that they're perceiving, their sensorium or cognition, their insight into the illness, whether they understand the illness or not, and their judgment of the current situation. Let's break that down further. Starting with the general appearance, attitude or behavior. What is appearance? What are we looking at? We are looking at how the overall client looks. What is the impression that they are making? How are they sitting in the chair? What kind of posture do they have? The kind of clothes that they are wearing. Are they clean? Are they dirty? Are they unkempt? Have they groomed themselves or not? Are their hair dirty or are they combed well? Suppose if you're talking about a female, are their hair all haphazard or have they tied that nicely into a bun or a ponytail? About nails, have they kept their nails clean? If you're talking, let's say, about a gentleman, a male individual who has come to see you. Again, is their shirt tucked in? Are they well kempt? Hair, beard, hygiene. How do they, sometimes even when an individual is sitting afar, you're able to understand the body odor, which is a signal have they bathed, not bathed, which means are they looking after their hygiene or not. So if the patient appears particularly bizarre, the clinician may ask, has anybody commented on the way that you look? You can ask direct questions in your MSC. Moving on, the attitude towards the examiner or the clinician. It can be described as cooperative, friendly, attentive, interested, or defensive, hostile, evasive, guarded. So an individual either might be friendly with you, they'll cooperate and they'll give you the answers that you're asking for. Or they might completely shut down, guard themselves and go quiet and not give you the answers. This could happen in the interview also, if the interview was going well and now suddenly something has happened that triggered them. Or it can happen right from the beginning of the interview, that they were too guarded and they were not willing to speak to the clinician. And that happens in a lot of cases where the family has brought in the individual. Because the individual, as we'll see in the upcoming slides, does not have the insight, which is the awareness about their own illness. Another key factor to look in the attitude towards the examiner is also rapport. Rapport is this mutual understanding of a back and forth bilateral dialogue that happens between the clinician and the client. So if they're able to develop a rapport easily or with difficulty, are they a little slow to warm up, were they friendly to go with, all this is noteworthy. Now, it's also important to see their overt behavior or their psychomotor characteristics. It can both be defined quantitatively or qualitatively. It can include mannerisms such as their way of speaking or using their hands. It could involve tics, maybe neurological or psychological, gesturing, any twitches, any stereotypical behavior that is a little repetitive, any rigidity in their sitting or in their walking. How is their gait? Do they lean towards one side? Is that again biological or psychological? Their pacing, are they hasty? Are they fidgety? Are they squirmy in their seats? And we also need to see if there is any significant psychomotor retardation, which is a general slowing of the movements. You'll also be able to see that in their speech. It has gone down, the tone, the volume, the rate of words that they are using, along with their psychomotor activity, which feels a little retarded. Coming to speech, like I mentioned, there are certain concepts that we can look at, which is the quantity, if they are talkative, garrulous, voluble, unspontaneous. We also have to look at the rate of production. So on an average, an individual produces 120 words in a minute in normal speech. So we have to see if they are going beyond that or they are going slower. You don't have to sit and count, but you would be able to understand that yes, the individual is either speaking too fast or too slow. The quality of speech, which is pressured, they feel like they need to blurt out everything, or a little hesitant, which you will see with guarded clients, or monotonous. There is no intonation in the way that they're describing their concerns. There is one monotone. Or maybe the opposite of that, which is being very, very dramatic, animated in what they are telling you. This speech impairment, which is stuttering or stammering, should also be included. It is noteworthy because we don't know if it's biological or medical. That is something that we need to also elicit in our case history, where we are talking about any past illness. So, medical history, it's important to elicit any stuttering or stammering which is coming from any neurological basis. So is with the tics as well. If not, we need to mention that in our MSc related to speech. Next, let's talk about the mood and affect. Let us understand that mood and affect are two different concepts, and the difference in them is on the basis of subjectivity. So, mood is a pervasive or a sustained emotion that colors the person's perception of the world. They have been in that mood, is what they are reporting. Now the description includes comments on depth, intensity, duration and fluctuations. It is also described using adjectives such as I've been depressed, I've been feeling euphoric, I've been feeling slightly irritable, slightly angry, anxious, guilty. This is all what the client would report when you ask them, how has your mood been? What you need to note is if the mood is labile, which means too constantly changing, or stable, or fluctuating, alternating between extremes. Labile also means that I'm not having the kind of reaction or a response as I should to the current scenario. I'm talking about something happy, but I don't have a happy expression on my face. Or I'm talking about something which is sad, but I have a smile on my face. All of this is important to be noted in the mood. Coming to affect, like I said, it's the present emotional responsiveness inferred from the facial expressions. This is more to be observed by the clinician than reported by the client. How I mentioned initially that mood and affect are very subjective. Mood is what the client reports, whereas affect is what the clinician notices. The clinician is you, the psychologist, or the psychiatrist. Now this includes amount and range of expressive behavior. It may or may not be congruent with the mood. Suppose the client has reported, oh, I've been very sad the past month. Now the affect you clearly saw is that of euphoria, of happiness. But what they're reporting their mood to be is sad or upset or depressed. It can also be described within normal range, constricted, blunted, or flat. These are all the kinds of affect that can be noted. How do we check the appropriateness of affect? Appropriateness is considered between the patient's emotional responses in the context of the subject the patient is discussing. Like I said, that if you're discussing a topic which is sensitive or mildly discomforting, upsetting, your affect should also look like that. That is an appropriate affect. Next, let's talk about the thinking and perception. There are various forms of thinking, starting with productivity, which is overabundance of ideas, too many ideas, flight of ideas, from one idea to the other. That day I saw a rose. A rose is red. Red is also the color of my friend's house. My friend did not come to see me when I was unwell. Maybe being unwell is also okay, but who do we know is okay or not? That is a reference of flight of ideas. That from one idea to the other, the mind is skipping. It could be correlating as well. Also to see in thought is the continuity. Sometimes the client would make some loose associations, or there would be lack of cause or effect in the relationships, in the patient's explanations. It might sound illogical, tangential, or circumstantial. Let's understand tangentiality or circumstantiality further. If you ask the client a question and they answer by starting somewhere else and they only briefly hit the correct answer to the question that you have asked, and then again they start talking about something else, that is tangentiality. You hit the answer like a tangent which hits the circle, even just briefly. Circumstantiality is that you are too elaborate about your answer, but it has nowhere even touched the question. It has not answered the question that the clinician has asked you. These two one would find a lot of times in clients who are currently going through a psychotic breakdown or a psychotic illness. Psychotic illnesses are your mania, are your schizophrenia, your delusional disorder, your paranoid schizophrenia. Psychosis or a psychotic disorder is where the individual is not quite in touch with the reality. And that is why in their responses, in their case history, in their questioning, in their interview, you'll see they're not quite able to answer the questions that you're asking them. Now you can also see language impairments that reflect distorted mutations such as incoherent or incomprehensible speech, a word salad, a jumble of words, something which is called neologisms. People tend to develop words of their own. These are all significant aspects that you can see in clients with the psychotic disorder. Next, we need to also look at the content of thinking. The content of thinking is if the client is preoccupied with their illness or their environmental problems, if there are any obsessions or compulsions which are present, any obsessions related to suicide, to homicide, any hypochondrial systems which are related to your body, your health, general health, any specific antisocial urges or impulses that the client is having, all that is the content. So content is that what is the theme of whatever the client is mentioning. It could be preoccupation, obsession, obsession with a certain thing, with your health, with a situation. It could be specific to urges, impulses. All of that is noteworthy. Coming to thought disturbances, you need to look for delusions if at all they're present. So delusions are these fixed, false, firm beliefs that do not conform to the environment or the culture that the individual is a part of. So in some cultures, how it is completely alright to cry at a funeral, in some cultures it is not, it is celebrated. As long as the individual is having that kind of a response within that culture, it's completely alright. But if not, then we can say that the individual is delusional. Some perceptual disturbances also that would be noteworthy in your MSc are they seeing, are they having any hallucinations which could be visual, auditory, are they seeing or hearing, perceiving something which is not there. Moving on to their cognition, which is their orientation to time, place, person, space. Do they know where they are, who they are speaking to, how did they come? All of that is also important. Then a significant part is also to assess their intellectual level, which can happen through any concentration or calculation exercises, serial subtraction such as subtracting 7 from 100, then again 7, then again 7 is also how you're able to see their intelligence. Another point that you need to see in your MSc is the memory, which is their remote like childhood, a recent one couple of months ago, or recent as in today or yesterday. Now coming to a very important point, which is their insight. Insight is the awareness about their own illness. Do they understand that they are in discomfort, they are facing challenges, those challenges are also being faced by the family. Those are different levels and you have to assess that at which grade of insight the individual is. That is all for today. That is your MSc with the client. Thank you.